Besides Alan, is there anyone else?
Matt, are you there?
Yep.
Hey guys,
Are you only seeing my slides at this point?
right now we are seeing your slides. Yeah.
Okay, I'm trying to do it a different way today, so
Okay.
we'll see if it works.
Hey again, it's Rahul and Antonio here. Henry worked an overnight, so we'll sort of facilitate this together here, and we'll give it a few more minutes before we get started.
And when I do that, you're just seeing the slides go through, right?
Yeah, I'm just seeing the slides.
Awesome. Okay.
No disclosures, Dr. Binder.
Yeah, I didn't actually put that in there, but it's true, unfortunately. How you guys doing over at Yale?
Oh well.
Yeah.
Not bad, not bad.
Roll, where are you from? Or where were you training before?
So I did my residency at Yale, and then I did my fellowship up at Connecticut Children's, and now I'm back at Yale doing my focus fellowship.
Cool. Awesome.
Yeah.
I don't think we've never met in person, have we?
I don't think so. I don't think we have.
Yeah.
Remind me, where did you train before? Tell me about yourself.
I was at NYU Bellevue and then Boston Medical Center, Hasbro in Providence for a year. And now I'm at Umass.
Cool.
Yeah.
Did you work with like Megan then when you were at Brown? You sure? Did you work with you?
Yes. Yeah. Yep.
With the Brown Fellowships, I don't think it's on the answer.
Yeah.
No, that group was great. I was only there for 12 months, but I enjoyed it a lot.
Yeah. Providence is a fun city too. I think pretty similar to New Haven in a lot of ways. It's a fun place.
Yeah.
Hey, Matt, Matt Milwaukee, I have to give you a shout out. We had one of the other clinicians that work in our ER and we had a kid with a horrible abscess to the foot. And we took your approach into the PT block higher up. And the kid said, the next day, he felt like he won the lottery because he had been in an ER the day before. And they told him he just had a wart and there was nothing that could be done. And this guy just like, he was walking barefoot at like a Six Flags and he had, he had like a huge friction blister, but below that, a massive abscess on his foot. So he was he was in so much pain that the PT block was like a nothing. And he was essentially we were able to do a pretty good job on that abscess. So we were thinking of you, and I was telling the person I was working at the time how awesome that presentation that you gave was. So thank you for that.
Yeah, if I could have one, I feel like that's it for peds because it's such a nasty area to get numb otherwise. And I never feel like I know what I'm fully getting into when I go into a foot like that. With whatever it's foreign body or stuff, like the planes don't fit right. So I feel like I'm going to be doing a little blind, and wherever I think I may make a poke or a dig, things move otherwise.
I'm only going to harass you guys with a little bit of nerve block talk today.
Love it.
Less than my usual. So.
And what do we got? Let's see.
3 more minutes.
Unfortunately for my
He's
fellows,
a stickler for 105.
He wants that 105.
Like I once tried at 104, and he's
I
like,
saw
"Oh,
that. I remember that. We're gonna
one more minute."
minute.
So we'll keep it. It's Henry's show. We'll keep it that way.
We got a lot of cases, man. I hope that's enough time. Matt, you won't mind if I ask you for lack of a better word, a specific question later in the presentation, will you?
No, that's fine.
I'm going to count on your expertise for esoteric knowledge.
Oh, a lot of my esoteric has left.
Okay.
One of my co-fellows who recently finished our ultrasound is like the king of those. He'll sit there in conference and like drop random eponyms and like Latin derivatives of things. And I'm like, what do you spend your day doing? Like,
Yeah. Not my thing, I can tell you that. But
Time's going by so slow. Do you have a bio for Zach to introduce him? If you're still on the program, I know. But just read what it says on. Just read what it. And Caroline.
Can you just get me? Can we just don't you say institution?
I got an email from Henry at 3 a.m., so I'm glad to hear he was working overnight.
All right, guys, it is 1:05. So again, Henry worked in overnight, as Zach just mentioned as well. So Antonio and I are going to sort of facilitate today's talk. Today, we have the honor of having Zach Binder from Umass, the PEM ultrasound director over there, give us a talk entitled, "Can I Get a Surgeon?" And without further ado, Zach. Oh, and Carolyn, oh, I apologize. I didn't realize, Carolyn, you're also chatting with us today too. So, so both of you guys, welcome, and thank you guys for being here.
Thank you. I appreciate it. And anytime we have the chance to present to this group is a pleasure and an honor. So once again, I'm Zach Binder. I think I know most of the people on the call, and my new colleague, Carolina Vega, who many of you also know is now an ultrasound fellow at UMass. So I'm going to present a few cases, and then hopefully we'll have some time for Carolina to present some cases as well. And sorry, in honoring Dr. Sivitz's tradition of trying to have a theme, I'm calling at least my portion of the talk, "Can I Get a Surgeon?" We unfortunately have no disclosures, so I'll jump right into case one. So case one was a 5-year-old previously healthy male. And just to kind of set the stage, I was working this shift with an extremely bright, competent emergency medicine third-year resident who I would easily trust to run my department on any day. And he went in to go see this patient and, quickly kind of came over and grabbed me and was saying, "Zach, I think you probably need to come see this patient right away." So I took that very seriously, especially coming from that source. So, we walk in the room, 5-year-old, had been previously healthy kid with just acute onset abdominal pain. And the story was he was at, whether it was school or daycare called mom, said, "You got to pick him up. He's got this really severe abdominal pain." And that was kind of it. No vomiting, no diarrhea. And when I walked in, the kid was prone on the bed, fetal position, legs drawn up, kind of had his arms over his abdomen and was just writhing in pain and moaning. I'd never really quite seen a kid in that much, overt pain or discomfort. So initial triage vitals, temp of 36.3, heart rate of 115, respiratory rate of 24. He was satting well, and his initial blood pressure was 81/48. And his like very cursory initial exam was notable for a distended abdomen, which was diffusely tender. He was otherwise awake and alert. And so the nurses were jumping on him and getting access, and I was plugging in the ultrasound machine, of course, and whether it was like the 3 or the 5 minute cycle, the next blood pressure post and his systolic blood pressure was like 65 over something. And still mentating and still kind of moaning, no clinical change, but obviously concerning development. So before I go any further with this case, I just wanted to kind of mention, this isn't something unless I've missed it, we haven't talked much about in this group. And this is kind of a construct that they often will use in the adult EM world. So, it's this algorithm for undifferentiated shock, essentially. So most typically medical patients, and it's kind of like a mnemonic or an algorithm for working up the undifferentiated hypotensive patient. Okay. And as I was saying, I'm not really one for like mnemonics or memory devices, but for some reason this one really stuck with me and I find like super easy to remember. So high map is the way to remember it. And the goal is you want a higher map, right? This is the hypotensive patient. And it stands for heart, IVC, Morrison's pouch, which is kind of like an allusion to a FAST exam, aorta, and then pulmonary. And while, typically this is discussed more in kind of an adult setting, and we used to talk about this all the time at Rhode Island, with the exception of aorta, we don't get a lot of aortic dissections or aneurysms. For the most part, this is very applicable in our patients. So when we're talking about heart, is there a pericardial effusion that's causing tamponade? Is their function just so depressed that, the pump essentially isn't working? Are we seeing signs of RV strain suggestive of something like pulmonary embolism? IVC, collapsed or full, we talk about this all the time, different implications to both, but can definitely be incorporated and be helpful in working up your undifferentiated shock. And for Morrison's pouch, you're looking at the traditional FAST views. The thought process is, ruptured ectopic, right? You're gonna have free fluid in the abdomen, but also some patients present as medical patients who ultimately you find out later, there's a trauma history. I know Adam, at least one of his cases last week, shows up at the non-trauma center. So, again, undifferentiated shock, you want to be thinking about that. And then P for pulmonary and pneumothorax. The last thing I'll mention before I move on, and this was something I always kind of stressed to the learners, is while this is the algorithm, this doesn't have to be the order that you do things. So, these are the options. And then based on the patient in front of you, I would prioritize, which exam I'm going to do first. If I have the tall, thin, lanky, male, I'm going to start with the lung looking for pneumothorax. If I have a kid with a cardiac history, or whatnot, I'll start with the heart. If the kid's had vomiting and diarrhea for a week, you might look at the IVC. So you can prioritize the order in any way you see fit. So the reason I bring this up is because I more or less essentially had an undifferentiated hypotensive patient at this point. And given the initial presentation, my first thought was to go, with the M, look in the belly and try to see what's going on. Okay.
And Zach, the one comment that came in was intussusception by Julie also, which kind of fits in nicely with the mnemonic as well, between the IVC and the Morrison's pouch.
Yeah, and when I'm thinking Morrison's, I'm kind of scanning the belly for all the above, obstruction, appendicitis, intussusception. I think I might share it differently because I'm not confident it's going to do what I want to do. So sorry, let me do this one more time. All right, give me 1 sec, guys. I'm sorry. I tried to get too fancy for my own good. All right. Are you guys seeing the clips now? Yeah. Okay. So again, when I walked in, this kid is writhing in pain on the bed. It took a slug of morphine and a significant amount of convincing just to get him willing to lay on his back. Okay. So that was kind of the situation we were dealing with. So these were kind of the quick initial views I got. So right upper quadrant, left upper quadrant, a cleaner view, nothing that was too striking at that point. So then I moved down to the pelvis and got these images. I can't see your guys' faces anymore, unfortunately. But so at this point, I'd like to open the floor. So aside from, starting to manage this kid's hypotension with fluids, or, I had pharmacy at this point drawing up pressors. What is your next course of action if, in this setting, when you're kind of seeing these images that I have up on the screen?
You got free fluid in his belly and some, generally speaking, kind of, I would say, like irritated, sort of non-specifically irritated looking small bowel to me, at least the bottom right.
Yep.
It looks a little almost like it's sort of that, it's flashing in and out, kind of like the fecalization sometimes you see when things haven't been moving well, and like more density and echogenicity to that than I feel like you usually see more kind of fluid filled in the actual like bowel itself.
Yeah, and like this was kind of the best I could do. The kid is still like squirming around and writhing, but I thought I had a decent amount of information here. But like practically speaking, so you physically see this. What is your like next course of action? Anyone willing to jump in? Hypotensive, severe abdominal pain, and this picture.
Zosyn, fluids, surgical consult.
Yeah. So, my thought process is I need, to get a surgeon on hand kind of ASAP, right? So in addition to, we page out and it goes to the junior resident first, this was one of maybe 2 or 3 times where I, at the same time, was directly paging the surgery attending, and just got them on the phone and was like, I just want to give you an early heads up. I'm at bedside. We have this hypotensive patient, acute onset abdominal pain, and I'm seeing, a ton of free fluid in the abdomen. And I think ultimately she had a really good poker face, because she was like, oh, okay, let us know when you get the preliminary imaging, and I'll send the resident down. And in my mind, I'm like, oh my God. But I think she was just playing it coy, for lack of a better term, because her colleague was down there, relatively quickly. I think she got the picture that I was worried. So this is the next image, essentially, that we were able to obtain. Severely obstructed pattern, clearly. Anyone have a thought as to what the underlying like pathologic process is, or likely to be in this case?
Does it have to do with one type of bowel being only on one side of the belly?
Probably, yes. Do you want to just, what are you alluding to, Adam? We lost him.
Malro and volvulus, or?
Yeah. So, when I saw those images, I wasn't really quite sure. I was worried about obstruction. I was worried about perforation. I knew the kid was sick, and really, wasn't able to go much beyond that. Adam, are you still there? I had a question that I was hoping to ask you.
Yeah.
So, and only because I know the kind of the culture at your shop, right? So, you see that ultrasound image, are you able to activate the surgeons, and like how does that go down? You know what I mean?
So just because we can see it in our ED doesn't mean that the total operations run very smoothly. But we have a good enough relationship with our peds radiologists that, you know, and with our peds surgeons that I can tell them and call them and kind of get senior people moving more than the interns moving.
Yeah.
But they're
So-
still going to want to do, you know, they're still going to do an upper GI on him. And
Yeah. So, and maybe I was thinking about this wrong, right? So it's not trauma per se. It's not trauma at all, but you have a hypotensive patient with severe abdominal pain and free fluid throughout the abdomen, you know, and I'm not a surgeon, but in my mind, I'm thinking, you know, this kid should go directly to the OR without any other imaging. Or, you know, I thought that was, you know, kind of what my thought process was at that point. And maybe I was a little off base, you know, I don't know. But so we got this x-ray, surgery came down to the bedside. We got a few quick images of a comprehensive bedside ultrasound, which showed, you know, the same thing that we had seen. And, you know, presumed diagnosis of Malraux with volvulus. This is, I think, the most relevant CT image. You know, you're kind of seeing all the central structures twisted on themselves. I'll make the quick point that, you know, I guess theoretically with ultrasound, you can see disorientation of the SMA and SMV. I don't know if that's anything anyone has ever ventured into. Certainly in this kid, I wasn't, I didn't have that opportunity. I don't know if anyone had a thought about that, but.
Antonio and I have a published case series with a couple of people that may be on this meeting. That when peds emergency care back in, when was that, like 2018, 19?
Yeah, a few years ago, mostly describing a whirlpool sign pattern. There were other findings for the midgut volvulus and bowel obstruction. But Zach, did anybody, when they did the comprehensive scan, did radiology look at the vessels coming off the aorta?
They didn't. Like they didn't get many more images than I did. You know, it was one of those kind of, you know, real quick look. And at that point, the surgeon was at the bedside. And then the next big question, and this has been the subject of, you know, multiple meetings and discussions at our shop, is was that enough to go to the OR at that moment, or was it the right move to go get a CT on the way to the OR? And I don't think we have a conclusive answer, and this has been bantered about, you know, back and forth. I think I've obviously revealed my bias, but I'm also not the one cutting into the patient. I think one thing that bought us a little time is he did respond to like 40 cc's per kg of NS. You know, his blood pressure was back in the you know, mid 80s range, and didn't have to initiate pressors at that point. And, you know, after the morphine was on board, you know, he was still in quite a bit of pain, but he wasn't, you know, writhing. But, you know, I thought it was an interesting debate, and I think I still am a little bit surprised we were willing to take so many steps on the way to the definitive management. But so taken to the OR, volvulus was reduced. He didn't actually need any of his bowel resected. And in one of these conversations, you know, I didn't fully appreciate this, but the head of surgery at our shop was saying, you know, generally speaking, you have 6 hours to save the bowel from the onset of symptoms. So if we presume this kid's bowel was, you know, being pinched off from the time he started having pain at school or whatever, we were probably damn close to 6 hours, I think, by the time, you know, his bowel was acted upon. Anyway, so, you know, critical condition post-op was on pressors in the PICU for like 24 to 36 hours, but ultimately recovered quite well. You know, the last surgery follow-up note was from a couple of weeks ago, and he was doing well. And then one final tidbit on this case that I was kind of interesting. So this was not revealed on initial history, but it was ultimately revealed that the patient had been worked up for intussusception like 18 months prior. And, had a quote unquote normal ultrasound. And then the question is, was he having intermittent volvulus at that time? My suspicion is he likely was, but interesting case. Any thoughts before I move on?
I mean, I'll just add that I think this morning I saw a tweet from ASEP that was quoting a paper from Tesaro up at Sick Kids, which was this case, minus a couple of years, but a 6-month-old that had been seen in an ED, investigated a couple of times for intussusception, and then they found the volvulus on their bedside ultrasound.
Yeah.
But in more advanced cases, trying to get to see those vessels can sometimes be really difficult because of the obstruction, and your gastric bubble kind of blows up. So unless you have an NG tube in there and really suck out a whole lot of air and bile and everything else, you may not technically be able to get to the vessels.
Yeah. I mean, for me, I kind of felt like I'd seen enough, and, but afterwards it was kind of one of those thoughts of, in another opportunity, it would have been cool to at least, take a look. So related case. So I think the first three all fall into Antonio's rule of 5. So, that was a distended abdomen. This is case 2. Okay. So 2-month-old with a history of gastroschisis, status post surgical repair on day of life 5, was presenting with like 12 hours of bilious emesis. Had been doing well. And then just kind of all of a sudden, per the parents, multiple episodes of bilious emesis. And they were really kind of harping on the fact that it was quite voluminous, big volumes. And as is always helpful, they actually had either like the shirt or the towel that the kid had vomited onto. And it looked, neon green. There wasn't much ambiguity. Okay. Initial vitals, temperature of 36.8, heart rate 124, respiratory rate 40, 100% on room air. And even before I actually saw what this kid physically looked like, just with that triage history, I'd put in for the portable KUB. So, that was ordered, and, walking down to see the kid. And surprisingly, he actually looked quite well. He was sleeping, he appeared comfortable. His abdomen was nice and soft, and he had, a healing surgical scar from his first week of life. So these are 2 ultrasound images, and I want to just impress upon people that this is the exact same stretch of bowel taken like 4 seconds later. So upper left, you're seeing the contents flow pretty vigorously from patient right to patient left. And then the exact same stretch of bowel on your lower right with, the exact kind of opposite flow. And I think we've talked about this in the past, and I've certainly seen where it's like, you certainly have forward flow, and then you're like, is that backwards flow or stagnant? But I mean, I'd never seen to and fro quite this, what felt like this straightforward. Okay. Obviously the bowel is dilated, and just keep in mind, this is a 2-month-old. So, when you're referencing kind of the dimensions, this is a little baby. And then we took a bunch of clips. I included this one because I think, this is the area that, this is at its widest point. This is just another stretch of bowel, just clearly like super dilated. And there was dilated bowel throughout his belly. Okay, so the clinical context, we see this, we see the bilious emesis. We're gonna, we drop our NG, and the logistical issue with this one was, we dropped the NG. I'll probably be in the room now, 10, 15 minutes. We still haven't seen, stat portable radiology. Call over. Oh, we have a number of traumas. And, you're on the list, right? So this is a 2-month-old with, overt, small bowel obstruction that we're being told, like, we'll get to you when we get to you, of course. So call the tech supervisor, call the radiology attending. Had a rather interesting conversation with the radiology attending. I was like, I have this 2-month-old, status post abdominal surgery, to and fro, very clearly in the small bowel on the ultrasound. I'm concerned this kid has obstruction. And her response was, that's not always obstruction when you see that, which I thought was very helpful, and didn't mitigate the fact that I thought, obstruction had to be ruled out. So eventually we were able to start getting, some imaging underway. So that's like the Scout KUB on the upper left. The middle image is the first shot of the upper GI that was taken at like 3:30 in the afternoon. So 15:30 by, Army time. And then almost a full 4 hours later is the image on the upper right. And that's the last in the series. Okay. So clearly not moving along very well. Okay, adequately. So patient ultimately went to the OR, had an XLAP, and the operative report had the term extensive lysis of adhesions in there, which, I've included there. He didn't require bowel resection, and he's still in the hospital. This was just a week ago, but, according to the notes, was recovering well, but, was requiring TPN and bowel rest and things like that. So, I thought I kind of put these cases together. These were two of the more probably acute medical cases I've taken care of in the last year. One with the, frank obstruction and hypotension, and then this baby just given the age. But, both ended up doing, relatively well, thankfully. So.
Hey, Zach, Dave Tang here. Good question. What led you to kind of, I know logistically you did one scan. What made you go back a couple minutes later to do it, or is it just in the context of just scanning the kids throughout? Is there a purpose for it, or is it just luck?
You're saying with the upper GI, the x-rays?
Yeah,
or?
you said, yeah, you had those two scans where one shows forward motion and then the back one is then backward. Was it just like, what I'm saying? Like, I'm just curious on what led you to do the second scan.
Oh, I just kind of was holding the probe and kind of trying to get a sense of what was going on.
Okay, got it.
It was within, both of these were within 60 seconds of each other.
Nice. Okay.
I'm just kind of sitting there, I see this huge bowel, and then I just wait, and a few seconds later, it's the one on the bottom right.
And then a few seconds later, did it return back to the other flow, or just curious?
Yeah, it just kind of kept
back and forth,
swish, swash, and then seeing areas like this where it almost just looked just tumultuous. It almost looked like a washing machine.
So are we officially calling this the Binder sign?
I mean, I think they see this stuff all the time in adults. We just don't see it as much in our kiddos, I think.
It's really nice catch. Really nice.
I think a good difference with this case, though, isn't just the to and fro, because I think I've seen to and fro on like regular enteritis, but like that also has very dilated loops,
right?
Which I think is like the other part, that the other side of the coin that's very important,
right? And even before I started looking for flow of contents, that catches your eye instantaneously, right? I mean, this is a 2-month-old, so right off the bat, you knew something was amiss, and then the to and fro kind of, I would say sealed the deal, but I guess it didn't exactly seal the deal for everyone. But I was like, okay, this kid's now obstructed. But these images, I can't really get over them, how crazy that looks. But all right, so should we move on from GI? So this is a cool case, and I'm going to bore everyone with my anecdote, but I think it adds to the the presentation. So a couple, what was it, in May, at our institution, once a month, we do like an educational session for the attending group. So we're a group of 8 and we rotate, and one person either, asks for a guest to come in or presents on kind of like a topic for the group. So in May, I, volunteered to, I actually asked one of the adult folks to come, present the fascia iliaca nerve blocks to our group. And we were going to do a session where, I give a little didactic, and then we go upstairs and look for landmarks and, in the hopes of convincing my group that, this is a cool thing for them to start doing. So we're getting settled in. Our office is like directly below the ED. And so we're a group of 8. So there's always one person post call, one person working. The other 6 of us were in the room. And I get a text from the person working, literally saying this: we have a 12-month-old who just walked in. He has OI. He has a gross deformity of his right upper extremity. Are you around? Might you want to do a nerve block on this kid? So I just thought that couldn't have been like more serendipitous. Like, I've done 5 of these in the last 12 months. And we happen to be like 100 yards away talking about this topic at that very time. So, the rest of the story is this kid had 20 prior fractures, kind of this classic OI story. Was at school, just innocently tripped, fell, developed severe leg pain and a gross deformity. Okay. And he was in so much pain that they couldn't send him into radiology. They had radiology come and kind of do a scout film. And this kid was also in, it was very memorable. So he was also laying prone, but so this is his right leg. He was laying like on the leg, this femur basically, which it was shocking to me that was his position of comfort. And, I really don't know what to make of that, but we had to give him like intranasal Versed just to, get him to kind of like take a few deep breaths and allow us to like rotate him slightly so we could even start to take a look at his anatomy. So, nasty fracture, obviously. I'm not going to bore you guys with this. We've gone over this in a number of different settings, but just, very quick reminder: nerve, artery, vein, lymphatic. I don't know if you can see my mouse, but this is the artery here. You have your honeycomb triangular nerve here. The needle is coming in laterally. The one interesting thing, oh, come on. Sorry, guys, I froze. Give me a sec. So anyway, hopefully this will end in a second, but I think the image on the lower right actually elucidates probably the hardest aspect of this block. So you can actually see that initially, so I should say, so, we did the didactic and then I went upstairs with the other 6 attending. So everyone in our group got to like kind of see the block in person, which was really cool. But you can see that initially, the person was infusing above the fascia iliaca, right? And the way we knew that in hindsight was you sort of get this obliteration of the tissue rather than the formation of this nice, clean, like anesthetic pocket. And now I'm wondering what I need to do to unfreeze this computer.
Are other people doing fascial iliaca blocks within their PEDs, or have other people started to explore that?
So, Roel, I don't know if you were you at not Scuff,
Yes.
P2?
Yes.
Yeah, so the paper that came out of that case series is going to be published soon. So I'm hoping you guys out there who are who aren't doing them very frequently will have some evidence to use with your orthopods and others.
That's great.
Caroline, are you there?
Yes.
All right, let me try this one more time. You might have to take over. My PowerPoint's like freaking out.
Sure.
Two quick checks while we get Carolina uploaded. Has anybody imaged adhesions before? If so, are they hyperechoic? I have not. So I'm gonna plead the fifth on that one. And then the other one is from Robbie Lindsay for adults diagnosing SBO. The classic 3 findings are multiple loops over 25 millimeters to and fro, and bowel wall, I guess, diameter over 2 millimeters.
Mhm.
Carolina, should I try one more time?
Oh, sure. I can unshare.
I don't know. This is so frustrating, but let me see if I can do it. No. Are you able to pull it up? Do you want to try? Or actually,
Can everyone see my screen?
Yep, we can see case 6.
here,
Yeah.
Carolina, do you mind actually just strolling through the last of that bit so I can just,
Absolutely. Let me just.
the way we said we weren't going to do it? I'll go quick. Yeah, so forward.
Oh, I cannot feel my leg when I touch it.
So I included that as hopefully further evidence for you guys. You know, this kid, this was actually 3 hours after the block. So he had been like crying, writhing, inconsolable, got the block. We were like, oh, seems to be having good effect. And then my shift started 3 hours later. So I went to go check in on him and his mom. And that was him. So that was pretty awesome. And I got permission. She was actually like a technician at Umass. So she was more than willing to let us include this video. Next slide.
Oh, I apologize.
So block went well. Kid was transferred to Boston Children's where he received all of his ortho care.
Shall we progress through the last 2 of your cases, Zach, or to mine?
You go ahead. I'll do them next time, I suppose.
Okay, so let's start with case 6. This is a 13-year-old female I saw that came in with mild generalized abdominal pain, nausea and vomiting for the last couple of days, mild per her description. Came in because this was different than how she typically felt, was previously healthy. Her abdominal exam was consistent with her description. It was non-distended, no focal area that had greatest tenderness. She was sitting up, seemed to be actively texting, was interactive, very unimpressive first impression, and her vitals were unremarkable. What would be your differential to anyone in the group at this point? Could be almost anything, right? Or nothing. And so we brought in the ultrasound because that's what we do. And what does your differential become when you see this? This was unexpected. So we can see some definitive free fluid here at the caudal tip of the liver. And so of course we progress down into the pelvis. And then this, I thought, very common to see this in adults, most likely, but very impressive in a child. We saw significant free fluid throughout the pelvis. You can see here the bladder, uterus doesn't appear to have any intrauterine contents there. We can start to see the ovary a little bit here, but on the next clip, you can see it even better. You can see a really nice image of the right ovary and the left ovary as well, what appear to be the tubes. And so very concerned for significant hemoperitoneum without obvious reflection in the vital signs or in her physical exam. What would be the biggest concern at this point? Probably not a pseudoaneurysm like the last presentation, but we get an HCG, which is lo and behold positive. Her H and H were remarkably within the normal range. And of course, at this point, most consistent with an ectopic, a ruptured ectopic, though we were unable to appreciate on our transabdominal images. Radiology trends, vaginal ultrasound did show a complex mass medial to the right ovary and significant hemoperitoneum. This required a right salpingectomy, and the patient ultimately did very well. Any thoughts on that case? And this one was not immaculate. There was admission that this was a possibility in response to the chat. Next case. We have a 1-year-old female coming in ostensibly for fatigue that started this afternoon, previously in perfect state of health for the parent. Did have 1 bilious emesis and 1 red stool this afternoon as well. On exam, she does have clinical mild dehydration, her mucus is dry, the abdomen is soft and non-tender, cap refill is normal, vital signs for at this point are fairly impressive, a little hypertensive, result could be sheep pain, could be inaccurate, due to stress from the vital signs.
Really,
Yeah.
like, is everybody's audio working okay, or is it coming out a little choppy or garbly?
Kind of sounds like the electric, like Tiny Diamond to me right now.
Yeah, Caroline, maybe you want to like fiddle around. Do you have like a separate mic at all, or is it part of your computer?
I can try.
No, it sounds good now. You're good. Never mind. Do whatever you just did.
Were people able to hear the last case or no?
Yeah,
Yes,
yeah.
yes.
We heard everything. That was great. It was just like the last like 15, 20 seconds. Not even.
Sure. So
Yeah.
this one, essentially the mother said she was perfect until noon. And then she became very tired. And then late afternoon, she had 1 bilious emesis, 1 dark green emesis, and 1 red stool. So she comes in, she says, my child is tired. That is her chief complaint. She does have dry mucous membranes, otherwise is reclining on the parent. Abdomen is benign, her perfusion's intact. Vitals are overall impressive, just a little bit of hypertensive if that's a true value. And so what would be the differential for the group at this point? Right, it could be a lot of things. We're worried about red stool. Are we having an intestinal issue? Do we have some sort of obstruction? Why is she so fatigued? Is she septic? She has no previous surgical history. And so we have a very exciting ultrasound. This is her right upper quadrant, which didn't have a lot of motion in that intestine, but nothing focal. And we actually progressed from the right upper to right lower, looking for something like a obstruction or an intussusception. Made it all the way to the left lower quadrant, and we saw this treasure. If anyone can pick out the abnormality here, this, and then you can see it even better on the next image here. So in the left lower quadrant, there was an approximately 4 centimeter structure. You can see the double ring, some edema, some free fluid, and this is a target sign and a pseudokidney over here, which we obtained by just moving 90 degrees. So interestingly, hers was located in an atypical location and was the reason for her current jelly stool. She produced one in the ED that was true current jelly. I had only read about that in textbooks. Seen many intussusceptions, but hadn't seen the current. And the radiology ultrasound said that yes, her intussusception went all the way to the rectosigmoid, was 4 centimeters, and the radiologist commented it was the largest one that they had yet seen. She had significant neutrophilia. Her hemoglobin at that point was, well, stable. Everything else was unimpressive other than the neutrophilia and the acute phase reactant. She ultimately failed air enema reduction, failed surgical reduction, and ultimately required a resection. So though it appeared that she had Doppler flow on the radiology imaging, ultimately lost flow in the interim or had low flow for a little bit too long of a period, but ultimately did well.
Hey, Carolina, can you go back to that one? So it's probably left upper, I think, just because it's abutting the tip of the spleen. And my guess, and like on the second clip, the clip that's still, and my guess is like differentiating it, the left lower and the left upper from, you know, a 1-year-old, it's like you're pretty much in the same spot. But anyways, it looks like it's pretty close to the spleen. And then the other one, if you go back to the first clip you showed, the right-sided, one more.
Nope, not quite.
This one. So for me, I think that actually might be psoas muscle and not a bow loop there, because it just looks like there's some vessels running medially to it and maybe a hint of a vertebral body. So
Yeah,
it's hard to know when you're not actually scanning, but when we look at bedside here, the first thing I ask the trainees to do is to find me the psoas muscle first, so you can sort of start at some sort of landmark that you can recognize. And they're not allowed to do the lawnmower or the inverted U or anything until they can identify the psoas muscle in the right lower quadrant. And that's something that's the way that we were taught to do it by our radiologists. So I think it's a nice thing, just because it has like little striated appearance and it's round, and sometimes it looks really big. And if you sort of put the probe on it right away, especially if you haven't done too many intussusception scans, it could be deceiving at first.
Right.
I think that's probably what we're looking at there.
Thank you, Antonio. But I agree. I see what you're saying with the spleen and my images, though the radiology one did ultimately describe theirs as left lower. Any other comments on this one? So this one is a 2-month-old female coming in with diarrhea for the last few weeks, tactile fever a few days ago, full term, otherwise previously healthy for the first 1 month. And the family says she's been feeding well. Vitals are unimpressive for her, and her exam is non-focal. What would be the differential at this point for the group? So obviously she's pretty young, so we're worried. Could it be an SBI? But they look fantastic. They're not febrile right now. They have not been taking any antipyretics. And reviewer systems is otherwise negative. So we do a scan. And we see this fascinating kidney. Anyone has any thoughts about this one? And so the most important thing about this is her right kidney, I believe. And I'll show the other side in a moment. The most important thing is that these, in a neonate or in a young infant, the pyramids appear relatively more hypoechoic with relation to the cortex, and the cortex appears relatively thinner in comparison to how it would in an adult. So you'll see these extremely dark renal pyramids, and that is normal in a young infant and a neonate. And so that you know that it's not hydronephrosis because you don't see any anechoic area in the pelvis. You don't see any true chalacetal dilation. So these are actually perfect kidneys. And then we look at the other side, and I included this one just for the learners in the group that this is a normal finding. This is the stomach if you shift a little bit too anterior when you're imaging, but normal kidneys on both sides. Ultimately, the partial SBI workup was negative. And radiology ultrasound, I ultimately obtained, even though it appeared normal to me, because the parent was very observant looking at the ultrasound and was worried about the what was described as holes on exam from their perspective. So, but they agreed, normal variant for age. And then just for comparison for the group, I included a normal kidney for an older child. You can see that for this 9-year-old, the pyramids are a little bit less or significantly less hypoechoic. Cortex is a little bit thicker. And then this is the left kidney for the same child. You've got significant or moderate hydronephrosis here, and you can see how it extends down into the pelvis. So that's a true hydronephrosis. Any questions about that one from the group? The chat I cannot see right now, unfortunately. Anyone could read out any questions that come up. Case 9. We have a 19-year-old male coming in with dyspnea and exertion. They had no fevers or chest pain. They have a past medical history of a sarcoma that we don't yet have details on at this point in the workup. Vitals are significant for significant tachycardia to 140, interestingly normal respiratory rate, and hypoxia to 92%. Does have diminished breath sounds on the left upper to mid lung fields. And so we decided to break out the ultrasound and saw this parasonal lung. And so right off the bat, you can say that this right ventricular outflow tract just looks too big. This is disobeying the rule of thirds. Taking a look here at our valves, the mitral valve is not as vigorous as I would hope. This certainly this appears to have reduced function. No effusion on this guy. And so we run through the rest of the pictures, and right from here, the right side obviously is just much too large, and we see significant flattening here of the interventricular septum. So I'm very concerned for right heart strain, nuance at right heart strain, given the association with his new symptoms. Here, this is the aortic level parasonal short. Again, we're seeing right atrium far too large, right ventricle. Here on the apical 4, we're seeing impressive resolution here in the right ventricle, I think because there's just so much fluid from the sides. You can see the moderator band and the chordae tendineae, and function just appears reduced. And some bowing of the septum. I include subxiphoid just to be complete. It underlies what we've already discussed, and this gentleman has significant plethora of his IVC. So at this point, I was very concerned for a giant PE or an acute PE. So we did obtain a CTA of his chest, which showed this. We have a very large saddle PE affecting this gentleman. And Sariana heparin drip ultimately went to the cath lab for targeted breakup of the clots. So that was very interesting. This was the first case I had seen in the pediatric ED. Ultimately improved. And the cardiology echo that they did had the same findings that we had at bedside, with the additional finding of some moderate tricuspid regurg, which you'll be able to see if you apply color to the apical 4, and some moderately depressed right ventricular systolic function, which we can appreciate that portion. D-dimer was interestingly not as high as I would have anticipated at 0.5 milligram per liter. So that was of note as well. More for ruling in than ruling out. Case 10.
Risk factors for this young man?
What was that?
Were there any risk factors for this young man?
The sarcoma, we were later able to elicit there was a history of an osteosarcoma that was in remission. And appears that was no longer in remission.
Oh, poor baby.
And so we have a 3-year-old female coming in for a high velocity MVC that was restrained and ended up having vomiting, was intubated due to a concern for altered mental status. Vitals, while intubated, were clinically stable, has no external signs of injury on the exam. But with the vomiting, of course, that creates a wide differential. Well, not that wide with trauma, if anyone has any thoughts at this point from the group. But we started with a quick fast before we went for radiology imaging, which showed a possible small pericardial effusion and a definitive positive right upper quadrant here. You can see some fluid here at the caudal tip of the liver. So we progressed to pelvic views, which again showed free fluid on both of these images. And so this kiddo obtained a CT abdomen pelvis with contrasts, which agreed with us. She did have hemoperitoneum throughout. Interestingly, they were unable to comment on or to identify the source of the injuries or lacerations. They measured the liver, spleen, and kidneys and said they did appear normal in appearance and had full standard trauma imaging and had no fractures or other injuries identified, and ultimately did very well. No intracranial injuries on CT head. And so that brings us to case 11. So this one, in contrast, Was a 5-year-old female that had an MVC several hours prior and looked great at the scene, was ambulatory, was restrained, asymptomatic, went home, comes back because much after the MVC started complaining of abdominal pain, was having some back pain, a few episodes of vomiting, appeared more tired than usual. So triage to the non-acute pod. And what's your differential at this point for this young lady? So they placed them actually a little bit of a hike from the trauma pod, but the description from the triage note seemed a little bit concerning. And so I walk in as my resident, very helpfully was already starting the fast, which is great. And I saw this as she arrives to the pelvis. You can see a stripe of anechoic fluid right here on the transverse view, sagittal as well. And so I'm very concerned for a moderately positive fast here with hemoperitoneum. And interestingly, at this point, we already have, my resident had already obtained x-rays of the lumbar and thoracic spine, which were negative due to the point tenderness there. With response to this, we got a CT abdomen pelvis, which showed an L2 pars interarticularis fracture that was displaced, that was invisible on our lumbar x-rays, and moderate hemoperitoneum. And again, no identified definitive source of or lacerations. So this kiddo went to the surgical ICU and did ultimately do well. But I thought it was a good learning point that if you were truly concerned for a vertebral fracture, CT really is more sensitive than X-ray. And that one did have a seatbelt sign. We have case 12. We have a 2-month-old female coming in with dyspnea, vomiting, and diarrhea for the past day. No projectile emesis when we're considering our full differential. Does have a complex cardiac history, but as is common, to be determined at this point, we were asked to look it up in the EMR, which is what my resident is actively doing at this point in the story. Patient was full term. Vital signs are significant for a fever, significant tachycardia to 210, significant tachypnea as well to 60s. Her SAT was 85%, which the parent says is not where they're supposed to live. It's not concordant with their cardiac lesion, and has a significant narrowing of her blood pressure. So at this point, concerned, do we have reduced stroke volume? Do we have blood loss? This child is in significant respiratory distress with retractions and flaring, and does have mildly coarse breath sounds, mildly cool distal extremities, but the pulses are intact at this point, and the child is alert. And so what is our differential at this point for this young lady? Right, we're worried about, could it be a decompensation of her cardiac issue that we don't yet know exactly what that entails for her? Could it be a significant hypovolemia, hypovolemic shock from all the fluid loss she's had for 24 hours? Is she septic? Is it a combination? And so I did a quick cardiac ultrasound as we were looking at the EMR and ordering other things. And I saw this parasternal lung, which right off the bat, you can see that the function of the LV appears okay, but you have significant thickening here on the right ventricle, right ventricular outflow tract, and it looks a little bit enlarged. And then also you see this, what appears to be an opening, which is very concerning for a VSD. And we look at the parasternal short, which we do see intraventricular flattening and D sign, which is a sign of right heart strain, which, as we know, can be a sign of acute change like PE, but it can also be a sign of anything that will increase volume or strain to the right ventricle, right? So it could be concordant with the VSD that we believe that we are seeing. Her tachycardia is extremely concerning as I'm doing this rapidly. And we have apical 4, which is a little bit oblique, but she does also have significant enlargement of the right ventricle and a little bit of bowing of the intraventricular septum right here. And we know that this, the orientation is correct, that there's not any switch because we can see the aortic outflow tract right here. And the subxiphoid imaging, again, supports what we've already discussed. And then I included IVC to see whether are we having any signs of plethora, and we do not. We interestingly have significant hypercollapsibility of the IVC. And so for this young lady, we did trial 10 cc per kilo bolus, which improved her heart rate significantly temporarily, and then we increased again. So we ultimately gave her 3, and that brought her down to the 160s. Concurrently, she started on high flow. We got an X-ray here that showed stable cardiomegaly compared with her previous films and significant new bilateral infiltrates. So she was also started on ceftriaxone and azithromycin. And we elicited the history by that point. She has at baseline, large VSD, small ASD, pulmonary overcirculation, and mitral regurg. Does typically take Lasix TID, which in the last 24 hours was lost to MSS. Cardiology echo did show a large VSD and moderate MR mitral regurg as well, with normal LV function, which is what we found, and otherwise was in agreement with what we had just discussed. Her blood gas was significant for respiratory acidosis, lactic acidosis, and she had no previous cardiac enzymes in her history, but those were significantly elevated as well, with a trope of 70 and a BNP of 300. So how much elevated compared to baseline, we will unfortunately never know. But ultimately, our diagnosis for her was acute hypovolemic shock from dehydration, along with respiratory failure and pneumonia. There was a discussion, could she possibly have an aspect of cardiac decompensation since we hadn't had the Lasix in 24 hours? But given the cardiology findings on exam and ultrasound, we held the medicine, at least for that night, after discussing with cardiology that they were in agreement, and she did improve with this management. So that was very interesting. The ultrasound was very important in determining her acute management on arrival to the pod with her significant distress. Any questions about that one or any of the other cases? And this is just my favorite scan of a toothpick, which wasn't worth presenting, but I thought worth including.
That was really
Antonio,
great.
I have
Go ahead.
I have 2 quick hitters. Should I just save those for next time?
I think so.
It's easy enough. I'll just
Yeah.
present them next time.
Yeah, I think so.
I don't get enough money to make those decisions.
I'll keep you guys in suspense until the fall. How about that?
Sounds great. But thank you guys. Those cases were all really awesome. I'm just going to take a quick look at the chat, see if I missed anything.
It was fun. Awesome images. That was fun. That was great.
Yeah, those were really great cases.
Lay, are you still there?
Yes, my friends.
So for you, on that first glance of that parasternal long, you're thinking chronic process?
No, I think retrospectively.
Okay.
No, I think, again, I think the challenge is that we don't see a lot of acute RV strain, but if you see a hypertrophied right ventricle, I presume there's some kind of underlying chronic issue, whether or not it's a TET or some other reason to have right ventricle hypertrophy. That's all I was trying to make. That's the only point I was trying to make.
Cool. Anyone want to jump in on that question from the way beginning in terms of like atraumatic, belly full of fluid, hypotensive? I mean, I guess, is anyone aware of like a clinical algorithm? Or, I mean, we're always taught that goes, straight to the OR, forgo CT in the trauma setting. I'm curious if anyone has any thoughts about that kind of clinical scenario.
I wonder, at least for us, it's how recently was the last M&M related to a similar pathology? So we've actually lately had a bunch of kids go very quickly to the OR because we had an M&M probably nearing a year ago now, with a very atypical, ultimately like neck in a kid who, one of those like not a preemie, not a brand new baby, doesn't seem to fit, but like the ED team, and I wasn't involved in the kid, was like very concerned and expressing things accordingly. And it was just like delay after delay, and like ordered the proper tests and they just didn't happen. And the kid ended up having like total bowel loss and dying. And subsequent to that, any kid with any sort of concern, like I had one not long after who was really tender and sort of intus, but was like so tender it was hard to even touch him, that like I didn't even try to get like multiple rounds of studies on. And within like 5 minutes of ordering, I had the radiology tech, resident, and attending bedside looking, and sort of giving definitive stuff right there. But we had a bad event, so everybody was like hyper acute about it.
Yeah. I was almost joking with my colleagues, like there should be a code word for like a medical case that is still seems like hyper, like someone comes in the trauma bay, everyone like responds with this like certain reverence or whatever. But, there are certain medical scenarios which are as urgent.
Yeah, I mean, I will say I've used POCUS to just call the surgery attending directly and just give them sort of my heightened sense of awareness. And then, a lot of times I feel like everything's going to be, I think, be case by case. But that that one magnet ingestion case that we had a very similar undifferentiated shock picture without trauma and a belly full of fluid by POCUS. And it happened in the middle of the night. So ended up getting cross-sectional imaging before going to the OR when the ER team was all, I think advocating to just take the kid to the OR right away. But it's these decisions that we have a little bit of input, but ultimately, has to be some sort of consensus building with other subspecialists. But slowly but surely, I think we'll get there.
Yeah, I mean, I think we just need to understand the limitations of ultrasound. And, there is a reason why they call the thing the donut of truth. So after some of our bad cases, even our peds radiologists, like just send them to CT, because if you need that answer right away, you need a complete look, that's the way to do it.
I mean, at least the way the chief surgeon was talking, we were probably, skirting on, let's say a half hour plus minus. I don't know. I know what you're saying, obviously, but.
Cool.
Yeah.
Well, yeah, it's a good thinking. It's a good sort of thought process, I think, for everyone's institution to navigate. But I really I think we all appreciate the cases. Those were really excellent images that you guys captured. And you guys went through so many of them, which is very impressive. It's a hard thing to get done. So just wanted to thank you guys again.
Thanks, everyone. It was a pleasure.
Great cases, guys. Thank you.